Okay, Grog. So, give me a sec, guys. All right, Groggy. So, let's talk a bit more about. We talked about the urinary bladder. We said about structure and the trigon. Let's talk about the exit of urine. So, we have an internal urethral sphincter and external urethral sphincter. Could you explain this?
The internal urethral sphincter, made of smooth muscle at the bladder's neck, is involuntary and stays contracted to prevent urine leakage, relaxing during voiding via autonomic signals. The external urethral sphincter, composed of voluntary skeletal muscle, surrounds the urethra and allows conscious control to start or stop urination, coordinated by the brain's pontine micturition center.
Okay. And what's the differences between elimination of urine in females versus males?
In females, urine exits through a shorter urethra, about 4 centimeters, making it easier for bacteria to reach the bladder, increasing UTI risk like cystitis. In males, the longer urethra, about 20 centimeters, passes through the prostate, which can obstruct flow if enlarged, complicating elimination and raising risks for infections like prostatitis.
Okay, what is micturition? Tell me about the micturition reflex, tell me about the two-stage process, and tell me about higher centers and cortical centers.
Micturition is the process of urinating, controlled by the micturition reflex, a two-stage process where bladder filling stretches the detrusor muscle, sending signals via pelvic nerves to the spinal cord, triggering parasympathetic signals for detrusor contraction and internal sphincter relaxation, followed by voluntary external sphincter relaxation to void. Higher centers, like the pontine micturition center in the brainstem, coordinate this reflex, while cortical centers in the prefrontal cortex allow conscious control, deciding when to delay or initiate urination based on social context.
Interesting. Let's talk about the sphincter and bladder innervation. So we've got the hypogastric, the pelvic, and the pudendal nerve.
The bladder's innervation and sphincters are controlled by 3 nerves. The hypogastric nerve, sympathetic, relaxes the detrusor muscle and contracts the internal urethral sphincter to store urine, while the pelvic nerve, parasympathetic, contracts the detrusor and relaxes the internal sphincter for voiding. The pudendal nerve, somatic, controls the external urethral sphincter, allowing voluntary contraction to hold urine or relaxation to urinate, coordinated by the pontine micturition center.
Okay, and what's the guarding reflex and what's continence? Explain to me during bladder filling what's going on.
During bladder filling, the guarding reflex keeps the external urethral sphincter contracted via the pudendal nerve, preventing urine leakage as the detrusor muscle relaxes and the bladder expands. Continence is maintaining this control, with sympathetic hypogastric nerve signals keeping the internal sphincter tight and cortical centers delaying the micturition reflex until voiding is appropriate.
Tell me one more time.
As the bladder fills, the guarding reflex activates the pudendal nerve to keep the external urethral sphincter contracted, stopping leaks while the detrusor relaxes. Continence is maintained by the sympathetic hypogastric nerve.
So in simple, can you tell me simply in simple words what's going on?
When the bladder fills, nerves tell the external sphincter to stay tight so you don't leak. Sympathetic nerves also keep the bladder
Whereas
relaxed.
the micturition reflex, what's the difference?
The micturition reflex is the automatic process triggered by a full bladder, where stretch signals via pelvic nerves prompt the detrusor muscle to contract and the internal sphincter to relax.
So they're the opposite.
The micturition reflex triggers urination by contracting the detrusor muscle and relaxing the internal sphincter when the bladder is full. The guarding reflex, its opposite, keeps the external sphincter tight.
What's the atonic bladder and what's an uninhibited bladder? Talk to me about neural disruption of micturition And yeah.
An atonic bladder, caused by neural disruption like spinal cord injury or diabetic neuropathy, lacks detrusor muscle tone, leading to urine retention and overflow incontinence due to failed micturition reflex. An inhibited bladder, often from higher neural issues like stroke or Parkinson's, can't initiate voiding because cortical centers or the pontine micturition center are disrupted, causing hesitancy or incomplete emptying.
Okay. Talk to me about drugs used in urinary incompetence. Talk to me about the what role will acetylcholine play with the pelvic nerve.
Drugs for urinary incontinence target bladder control. Antimuscarinics like oxybutynin block acetylcholine to relax an overactive detrusor, reducing urgency incontinence, while beta-3 agonists like mirabegron enhance detrusor relaxation for storage. Acetylcholine, released by the pelvic nerve, parasympathetic, stimulates muscarinic receptors to contract the detrusor and relax the internal sphincter, triggering micturition and normal voiding.
Okay, and can we talk about oxybutynin and imipramine? How would they work? And explain their naming too.
Oxybutynin, an antimuscarinic, blocks acetylcholine receptors, relaxing the detrusor muscle to reduce urge incontinence and overactive bladder symptoms. Imipramine, a tricyclic antidepressant, inhibits bladder contractions and tightens the urethral sphincter via anticholinergic and alpha-adrenergic effects, helping with mixed incontinence. Their names derive from chemical structures, with oxybutynin reflecting its oxygen-butyl chain and imipramine from its iminodenbenzyl core.
Interesting. And okay, what about alpha-1 alpha adrenoreceptors? And what about prazosin?
Alpha-1 adrenoreceptors, found in the internal urethral sphincter, contract the sphincter when activated by norepinephrine, promoting continence. Prazosin, an alpha-1 blocker, relaxes the sphincter by inhibiting these receptors, aiding urine flow in conditions like benign prostatic hyperplasia, but may cause stress incontinence as a side effect.
And what about bethanechol? What's that?
Bethanechol, a cholinergic agonist, mimics acetylcholine to stimulate muscarinic receptors, prompting detrusor muscle contraction and aiding urination in cases of atonic bladder or urinary retention. It's used cautiously due to side effects like sweating or gastrointestinal upset and doesn't directly affect alpha-1 adrenoreceptors.
Okay, let's go back to UTIs. We have lower and upper UTIs. So, what's the difference between lower and upper? I don't understand.
Lower UTIs, like cystitis and urethritis, affect the bladder and urethra, causing burning urination and frequent urges due to bacterial infection. Upper UTIs, like acute pyelonephritis, involve the kidneys, leading to fever, flank pain, and systemic symptoms, often from bacteria ascending from the lower tract.
Okay, let's talk about dysuria, nocturia, cloudy urine. Let's talk about clinical diagnosis of cystitis and other infections.
Dysuria, painful urination, nocturia, frequent nighttime urination, and cloudy urine due to bacteria or pus are hallmark symptoms of cystitis, a lower UTI, often diagnosed clinically by these symptoms plus urgency and frequency, confirmed by urinalysis showing pyuria or bacteriuria. Other infections like urethritis may show dysuria with discharge, while pyelonephritis includes systemic signs like fever and flank pain, requiring urine culture or imaging for diagnosis.
What is leukocyte esterase and...
Leukocytosis is an elevated white blood cell count.
Leukocyte esterase.
Leukocyte esterase is an enzyme in white blood cells, detected in urine tests to indicate pyuria, a sign of UTI like cystitis. Its presence, often with symptoms like dysuria or cloudy urine, supports a clinical diagnosis of infection, though urine culture confirms the specific bacteria.
Okay, let's talk about laboratory diagnosis now and midstream urine.
Laboratory diagnosis of UTIs relies on midstream urine collection, where the patient voids the first urine to clear the urethra, then collects a clean sample to reduce contamination. Analyze for bacteria, leukocyte esterase, and nitrites. Urinalysis showing pyuria, white blood cells, bacteria, or positive leukocyte esterase nitrites, combined with a urine culture identifying over 10.5 CFU per milliliter of a single pathogen, confirms infections like cystitis or pyelonephritis.
Again,
Midstream urine, collected after initial voiding to avoid contamination, is tested for leukocyte esterase, nitrites, and bacteria to diagnose UTIs. Urinalysis showing pyuria or bacteriuria, plus a urine culture with over 10.5 CFU per milliliter of one pathogen, confirms cystitis or other infections. So we were discussing how midstream urine is
and what is the antibiotic treatment then in this situation?
Antibiotic treatment for uncomplicated cystitis typically involves a 3-5-day course of nitrofurantoin or trimethoprim sulfamethoxazole, targeting bacteria like E. coli. For pyelonephritis or complicated UTIs, broader spectrum antibiotics like ciprofloxacin or ceftriaxone are used for 7 to 14 days, guided by urine culture results.
And how do we know about antimicrobial resistance rates? And how do we prevent UTI?
Antimicrobial resistance rates for UTIs, like those caused by E. coli, are tracked through local and global surveillance, such as the WHO's GLASS report, showing high resistance to drugs like trimethoprim sulfamethoxazole up to 40-50% in some areas, and rising resistance to fluoroquinolones. Local hospital data and urine culture sensitivity tests guide treatment choices. UTI prevention includes good hygiene, wiping front to back, staying hydrated to flush bacteria, urinating after intercourse, and avoiding irritants like perfumed products. For recurrent cases, low-dose prophylactic antibiotics or non-antibiotic options like cranberry supplements may help.
Okay, what about catheter associated UTI? And how do we prevent catheter associated UTIs?
Catheter-associated UTIs, CAUTIs, occur when bacteria, often E. coli or Klebsiella, enter the bladder via an indwelling catheter, causing infection with symptoms like fever or cloudy urine, confirmed by urine culture. Prevention includes using catheters only when necessary, removing them promptly, maintaining sterile insertion techniques, and using closed drainage systems. Regular hygiene and antibiotic-coated catheters can further reduce risk.
Question: what about asymptomatic bacteriuria? And also explain us the concept between relapse versus recurrence.
Asymptomatic bacteriuria is when bacteria are present in the urine, detected by culture without symptoms like dysuria or fever, common in pregnant women or catheterized patients, and usually doesn't need treatment, except in specific cases like pregnancy or before urologic procedures. Relapse is when the same bacterial strain causes a UTI again, soon after treatment due to incomplete eradication, while recurrence involves a new infection, often with a different strain, typically weeks or months later, linked to reinfection or host factors like hygiene.
And lastly, just a bit regarding renal disease. Can we talk about CKD stages? I know this, guys, is not a good introduction, but I think we have a lot on renal disease in other episodes. Yeah, let's talk a bit about CKD stages and how we suspect for kidney disease.
Chronic kidney disease, CKD, is staged 1 to 5 based on glomerular filtration rate, GFR. Stage 1, GFR greater 90, has normal function but kidney damage. Stage 2, GFR 6089, shows mild loss. Stage 3, GFR 3059, moderate loss. Stage 4, GFR 1529, severe loss. And stage 5, GFR less than 15, is kidney failure needing dialysis. As CKD progresses, aspects like hypertension, proteinuria, or infections worsen, increasing risks of complications like anemia or cardiovascular issues.
So,
Managed through
with explain me nephrotic syndrome now, and explain also why we would have low serum albumin and generalized edema. And explain nephritic syndrome. Explain the difference. So one has to do with the nephron, the other what has to do with.
Nephrotic syndrome is caused by damage to the glomerulus in the nephron, leading to massive proteinuria, or 3.5 g per day, low serum albumin due to protein loss in urine, and generalized edema from reduced blood osmotic pressure pulling fluid into tissues. Nephritic syndrome, also from glomerular damage, features hematuria, hypertension, and mild proteinuria due to inflamed glomeruli, reducing filtration and causing blood in urine, differing from nephrotic's focus on protein leak.
I don't get the difference. Tell me again, and I want you to also tell me about diabetic nephropathy, and explain to me tiredness, swelling legs, etc.
Nephrotic syndrome, caused by glomerular damage in the nephron, leaks massive protein into urine, dropping serum albumin and causing generalized edema from fluid seeping into tissues, with symptoms like swelling. Nephritic syndrome involves glomerular inflammation, leading to hematuria, hypertension, and less protein loss, showing blood in urine. Diabetic nephropathy, a CKD cause, damages glomeruli from chronic high blood sugar, causing proteinuria, tiredness from anemia or toxin buildup, and leg swelling from fluid retention. It progresses to CKD stages, managed by glucose control and blood pressure meds.
Okay, so nephrotic is protein that goes to the urine, and then nephritic is inflammation.
Yes. Nephrotic syndrome is when damaged glomeruli leak lots of protein into urine, causing low serum albumin and edema. Nephritic syndrome is when inflamed glomeruli cause hematuria, some proteinuria, and hypertension, with less
When
protein loss.
do we use nuclear medicine in renal disease?
Nuclear medicine, like renal scintigraphy, is used in renal disease to assess kidney function, blood flow, or obstruction, particularly in cases like CKD, hydronephrosis, or transplant evaluation. It's valuable when ultrasound or CT lacks functional detail.
Okay.
Using
Thank you for watching, guys.